So I'm David Pryor from Ascension. It's a pleasure to be here, and I appreciate the opportunity. I am reminded by the cup half full and half empty statements, of course, that the optimist it's half full and the pessimist it's half empty. But of course, to the engineer, it's twice as big as it needs to be. So Ascension is a very large system. Right now we have over 130 hospitals, as Brent mentioned. We employ around, I think somewhere on the order of about 180,000 associates. We employ about 6,000 providers and have over 50,000 that we work with. We train about 2,000 residents a year across the system in different programs. So it's a big, big system. We have everything of every type. We have 1,900 places where care is provided and multiple different components. And I think probably the reason that I was asked to speak is because we've had some success in the quality arena, and people will use us sometimes, I think, as saying, well, if a large system can create positive change, then positive change is in fact possible. So what I've selected today is really 5 slides. The first 3 slides are really about improvement results and talking about our quality journey that we've been on. The last 2 slides are really more what I would call look at as sort of impact slides, as examples of things. And then I want to conclude my remarks with sort of directions that we are moving forward in the future and where we're going. So this slide was published in Health Affairs in 2011, and at the time this represented the work that was done in 68 hospitals. And you can see these are comparisons of performance across Ascension Health compared to national averages. These are the reductions compared to national averages. So our quality journey began in 2002 when we committed ourselves to excellent clinical care with no preventable injuries or deaths. And we actually did a lot of work and tried to understand how many deaths were preventable. And we went back to the New York State studies and the Colorado-Utah studies that have been referenced, and said that we think perhaps 900 lives could be saved. And I would sometimes talk about asking for a moment of silence for the 3 people who died in our system today who didn't need to. And we developed a whole series of priorities for action around that work. Those 8 priorities for action, we had some help from Don and Maureen and IHI in identifying the right priorities that we should be focused on and working with. And they're very similar to the 100,000 Life campaign and now the HEN work that has gone forward. And as you can see, there were substantial improvements that occurred in our system with, for example, pressure ulcers being 94 and 95% lower than national averages, or neonatal mortality being close to 90% lower. The next element of work that we did, we called Healing Without Harm by 2014. And Healing Without Harm was our way of capturing that what we wanted to do was commit ourselves to being a high reliability organization and shifted our focus not simply from high-risk areas and processes where we had standardized the work, but now began to focus on analyses of individual events, classifying and looking at each of those individual events in a common way across our entire system. We trained on the order of 120 or 130,000 people on high reliability approaches and techniques, management approaches, focusing on cultures, creating reporting cultures, and a whole series of work over a period of time that did that. And because the work was phased in over different times, what you're seeing on this slide is the true baseline is shown in the green line here, and this represents, through August of 14, a 75% reduction in serious safety events. Now, because these events are all reported, and they are reported into a common system, although we are migrating the system now, which confounds some of the more recent results, We were very concerned about voluntary reporting systems and wanted some outside check on that process. We also have a reporting system for our malpractice events. And in the malpractice system that we have a series of events that we call basket ones that are likely to result in potentially compensable experiences. And we instituted in our program a requirement that basket ones had to be reported within 24 hours of their occurrence, and if they weren't, the individual hospital was on the hook for an extra $100,000 or $200,000 in first dollar coverage. And what we've been able to demonstrate is that approach gets the basket ones reported with better than 96 or 97% accuracy. Because there's a significant advantage in doing that. And what we did was go ahead and compare the decline in serious safety events with the basket one reductions. Not all basket ones are serious safety events. So an accident in the parking lot, for example, we wouldn't necessarily consider a serious safety event for a patient, but probably would be a basket one in our system. And what you can see here is that they parallel each other fairly well. And when we did a preliminary study where we tried to match up for concurrent times, the equivalent basket one reductions with the serious safety event reductions for what basket ones would be serious safety events, it was 65 versus 68%. So we had some confidence, in fact, that maybe we really were making some improvements. What I'm showing here is the first of the two outcome slides. This is our professional general liability performance, and probably the best measure for this that's due to patient safety, although it's a trailing indicator, would be professional liability cost per unit of exposure. What this shows is a 40% reduction overall that represented close to $400 million in savings for us since FY05. This slide, which is my last slide, really shows the overall lives saved each year since we began our work in measuring that, going all the way back from FY05. The model used here is the Premier Adjustment Model, which was the Care Science model before the Premier model. So in fiscal year 15, for us, we saved an estimated 9,041 fewer mortalities that year compared to what would have been expected in 2004. What I'd like to do now is just turn to sort of directions that we are moving forward in the future. And I thought about how to group these, and the first comment that I would make and things that I'm concerned about is I'm worried about my system having become complacent. We have some evidence that is concerning to me. If I look at more recent results, although it's confounded by new reporting systems and for reporting serious safety events, I'm seeing a divergence now between the basket one rates and the serious safety event rates. It needs more work, and I'm not sure it's there, but at least in some of our organizations, I'm worried about some complacency that is present. We've also seen for the first time, we look at raw mortality, and we're seeing raw mortality in the system has increased a little bit slightly, but the care, usually that's accompanied by an increase in the case mix index. In this case, it was not, so that also makes me concerned, although the case mix index and the adjusted mortality models themselves are different. The second place that we are focused on is that these measures that I'm showing you are primarily around inpatient safety, which is far from adequate for creating the overall quality in the programs and the systems. And so we are dancing around the edges of the next kinds of areas. We are looking at some ambulatory measures and some system measures. We are looking at with a tremendous amount of activity in the patient engagement approaches and things that we're working on in that dimension. And so looking at a number of different kinds of measures as we do that. We are beginning to think about and beginning to look at not only the patient-centered issues, but also the efficiency issue and also the equity issue across our system as we look at that work. but we still have not hit even all of the dimensions that were identified in quality in the original reports, and still have substantial work left to do. The third comment I wanted to make is really around larger things we're doing around reorganizing ourselves, looking again at culture issues, looking at how we reframe the governance structure across the system, thinking about setting up common metrics and systems. And we are bringing together all of the data and the analytics and the research across the organization as we think about, although it will be distributed and function, how we do that going forward. And I think one of the key issues that also has to be addressed, certainly at a cultural level, is we actually focus on a quadruple aim, which is the triple aim plus our fourth one is provider satisfaction. And we do that because we think that's essential in order to be able to create the kind of culture and to deliver the kind of system we want to deliver. And as we do that particular work, I will tell you that I do not believe 10 minutes for a physician visit is an adequate time for a good experience for either a physician or a patient. And we start talking about changing the culture and the dynamics, and I think we're going to have to relook at the process models and how we work. Thank you very much.